bit about vancomycin in children with PSC with Drs. Kenneth Cox and El-Youssef. Thank you very much for being here. So, I'm very curious, what led you to test the vancomycin in patients with PSC? How did you end up with selecting this drug?
I followed him.
Well, I mean, I could go through a talk which kind of gives the history of the Vanco and the PSC, and also some of our research experiences, and give an opportunity for people to ask questions as they go along. But I think that, again, the PSC that we've been focused on for the Vanco is that associated with inflammatory bowel disease. You see PSC in a lot of other conditions, and that's not what we've been studying, like cystic fibrosis, histiocytosis, and algaeals, and all this. But our patients have been mostly IBD, but some of them don't have IBD, that don't have any of these other diseases, have responded to therapy. And again, our diagnosis of PSC is MRCP or ERCP and liver biopsy. We have a subset of PSC patients that only have small duct disease, so their MRCP is normal, but they have PSC on liver biopsy. And then there's overlap, so a lot of them have autoimmune markers, and then the question is, do they have autoimmune hepatitis with PSC, or is it independent of PSC? Is PSC independent? And so we've put together a recent review article of the literature, and I think, again, one of the things that we see is it's a common cause for liver transplants, particularly in Scandinavia. In the United States, it's the fifth most common reason to do a liver transplant. And that the PSC has also a high reoccurrence rate in the transplanted liver, 17% in adults, 10% of children, saying that it's not a primary liver disease, but it's something that's affecting the liver. And then the risk of cholangiocarcinoma in about 10% of adults. We've had a lot of standard therapies we've used, and it's not been very effective. We've used immunosuppressive therapy, 𝐀𝐝𝐝𝐢𝐭𝐢𝐳 digoxy, which may lower your numbers, but doesn't get rid of the inflammation. Often the liver disease progresses, even though the liver numbers look great. It doesn't make the progression go away. So my experience was it was in 1993, so over 20 years ago, about 25 years ago. I had a kid that had C. diff and had colitis and had PSC, and I treated his C. diff with Vanco, and I noticed his liver numbers became normal and his colitis resolved. And I thought, well, maybe it's somehow related to C. diff. So then I stopped the Vanco, and he flared. His liver numbers went sky high again. And so I said, well, the C. diff's gone. Let me try it again. And they all went down, right back on the Vanco. And then I did 2 kids with Crohn's disease with PSC, and they responded too. Their liver numbers got better, their imaging got better. This kid, he had an ERCP showing that the strictures all went away on the Vanco, and that was the publication I did in 1998 on these 3 cases. And that sort of set me interested in Vanco. I had no idea that Vanco would do this, and then the question is why? Why did it do this? And again, Vanco has 2 effects. One is an antibiotic, but it also is an immune modulator. People take T cells, put them in a culture media, put Vanco in there, they don't release the cytokines. And so it inhibits cytokine release from T cells. So the question is this affecting the bacteria, or is it affecting the T cells, or is it the combination of the 2 that's making the response? And so what we did in 10 years ago, we looked at 14 kids we treated, because again, we still hadn't set up any prospective research study, because it was kind of a questionable issue. Is does this really work with PSC? And so we had 14 kids that we published that also all responded to the Vanco. One of them had C. diff, the others did not. And we started giving a dose of 50 milligrams per kilogram up to 30 kilos, and then 500 milligrams 3 times a day. It was an arbitrary decision on that dose. It's just what we had used in these other 3 patients. And so we thought, well, let's use a standard dose, knowing that maybe a different dose would be appropriate, but that's what we ended up using. And again, these patients all responded. All 14, their liver numbers got better. And so again, I was convinced this thing was working. Now 14 kids responded to it, and their numbers got better within a couple of months. And again, we had them sclering when we stopped. Most of them, when we stopped the therapy, their numbers went back up within a couple of months. What was sort of interesting is that a lot of them had autoimmune markers. 12 of them had autoimmune markers of the 14, and some of the autoimmune markers became negative on the Vancomycin. So the ANA on 4 was negative, the anti-smooth muscle antibody was negative, and the 𝐀𝐝𝐼𝐭 became negative. So it also told me that somehow it was shutting off the immune reaction with these immune markers becoming negative. So again, our experience with those patients is that their numbers got better, their liver biopsies and imaging got better, and they seem to have improvement of their IBD on the Vancomycin as well. And so we thought maybe we needing to do some research to try to understand why does this work. So what we did is we had 14 patients 2 to 16 years of age, 9 patients 2 to 16 years of age that had PSC and ulcerative colitis, and we put them on this dose of Vancomycin. And what we did is we looked at more detail, did they respond? We did colonoscopies on 7 of them before they were on Vancomycin and then on Vancomycin, and 4 of them had complete resolution of the colitis in the biopsy. 3 of them had minimal inflammation on biopsies, and then 2 of them wouldn't let us do the colonoscopy, but they were asymptomatic. We did liver biopsies on 9 of them. 5 of them had normal liver biopsies. 3 had fibrosis without inflammation. 1 had reduced inflammation. And then we looked at their immune reactions to this. Again, the GGT went down within 1 to 3 months to normal, almost normal in these patients. And we looked at their cytokines. Their TGF-beta went up significantly. Their TNF-alpha, IL-4, IL-13 didn't change significantly. But the TGF-beta stimulates Tregs, which has an anti-inflammatory response. And so we looked at the Tregs, and they went up on the Vancomycin. And the T effectors went down on these 9 patients. And then we had one interesting patient that we had on Vancomycin and got better. So we said, well, let's see what happens when we stop the Vancomycin. And we looked at his Tregs, and his Tregs dropped significantly over 9 months. And then he started having symptoms. His colitis came back, his liver numbers went back up. We put him back on Vancomycin, and his Tregs went right back up again, and all those symptoms went away. So we do think it has an immune modulating effect on the T cells. And whether is it a direct effect on the T cells of the gut, or it's an antimicrobial effect that's affecting the T cells, but it clearly, or the combination of the two. So again, our feeling is that Vancomycin works, and it's probably both on the T cells and changing the microbiota. And we did look at microbiota on 34 PSC patients compared to 17 healthy controls. We haven't published this yet, but this was another of our research study. And what we saw was primarily lack of diversity of the microbiota in the pre-treatment patients. If you look at their microbiota, they were less diverse than the normal controls. And then obviously they go way down. But then when we took them off Vancomycin, they went back up, but they still lacked diversity compared to the normal controls. We didn't see a specific pattern to this. Others have, and that can be commented on, but there was just lack of diversity that we saw. And so I have a poster that I'm going to have on Monday, but it's basically reviews 59 patients that we've treated with Vancomycin and PSC. 45 were children, 14 were adults. And what we saw is, and 94% of them had inflammatory bowel disease. 3 patients did not. And their diagnosis was with MRCP, ERCP, and liver biopsies. 9 patients had normal MRCPs, and it was only the liver biopsy that showed the PSC. And then we put them on the same dose that we've been using in our clinical therapy patients. And so these patients have a treatment time of 2.7 years, the median, 3 months to 14 years. And the reason that some of them stay on it long term is every time we tried to take them off, they flared. And so we had to put them back on. Some of them came off, so our protocol was to treat them for a year and then try to see if we can wean them off. And about half of them we eventually weaned off, but the other half flared a lower dose or when we weaned off, so we had to put them back on the Vanco. And so we had no side effects in these 59 patients. 67% of the patients that had symptoms of their IBD got better on the Vanco. And for most, the treatment was stopped or dose was reduced after 1 year. And that was our goal. And one patient had cirrhosis and had to have a liver transplant. All his liver numbers normalized when he was on the Vanco, and it took 8 years. He had a very bad liver disease when we put him on Vanco, but it was 8 years later they ended up with a transplant. No one else needed a transplant. And then if you see the liver numbers in the first month dramatically decreased, and particularly the GGT and the ALT, the ALK-Phos was not as sensitive. And I think that's in part because a lot of these patients had growth spurts on the Vanco because they had the inflammatory bowel disease became inactive and they started growing, and I think the ALK-Phos went up in response to the growth. So I think particularly in kids, I think I'm concerned that the ALK-Phos may not be reflective of the bile duct as much as the GGT. And I have an interesting kid with PSC and IBD who responded to the Vanco, and his dad had normal liver function studies but never had a GGT. And the dad said, well, should I get a GGT? And then we did a GGT on him, and it was high, had an MRCP, and he had PSC. And so I think sometimes some of our IBD patients are missing PSC. And I think the GGT, particularly in kids and maybe in adults, should be something that we're doing. So the ALT decreased in 100% of patients to normal in 59%. GGT dropped in 91.5%, normal in 44%. And MRCPs improved in 76% of patients. 22% or 10 didn't have any change, and 1 had increased strictures. This one that had increased strictures was put on a variety of different brands of Vanco, and we had one brand of Vanco that we were having flares with, Acorn, and we studied the Acorn brand in the lab, and the capsule didn't dissolve until the pH was 9. And so we began, and then we had 3 other patients that flared when they switched to the Acorn, and I think it may be because the capsule wasn't dissolving as rapidly. And then in the liver biopsies, 19 of them had, and 9 of the patients had normal MRCPs, and 1 of those patients showed no significant change. 8 of them marked change in their biopsy. So 78% of the patients had either MRCP or liver biopsy that improved. And then there's some adult studies now from the Mayo Clinic, and there's one from Iran. There was a placebo-controlled study in Iran recently published that looked at, and these patients were on Urso, and the patients within were put on either placebo or a Vanco, and on the Vanco their numbers got better. So again, in these adults, they showed the Vanco was an additional benefit to the ursodiol. I won't talk about the other Mayo studies since I have the experts here. And then one other thing that we had one patient we published that had recurrent PSC after transplant. We put the patient on Vanco, the numbers dramatically improved, and biopsy showed evidence of recurrent PSC. We now had 9 that have had recurrent PSC after transplant, and they've responded to Vanco. So again, I think it's a group of patients that might think about Vanco if they have recurrence after their transplant. So, basically, we think Vanco has been fairly effective therapy, and I don't think we've had other therapies that have been this effective, and I think 1 is it's affecting T cells, and 2, it's changing microbiota that may be stimulating the T cells. But I do think, having a a prospective controlled study might be a good idea with placebo, so we can convince everyone this is the right therapy. And it is costly. So one of the things that I've had to do with some of my patients, I switched them to IV Vancomycin that was compounded because it was 1/10 the price of the pill. And so I ended up doing that as a way to reduce the cost. And so anyway, any questions for me at all before we move?
I just have a quick question about the patients in this most recent data that you're presenting. Were any of them on the compounded Vanco, or were they all on the capsules?
They were all on capsules, but some of them ended up switching to compounded after a year. And it was because, you know, they were paying out of pocket for it. And then again, it drives me to try to lower the dose. And some of them I could get down to 250 a day, and they didn't relapse. And so that's one of my motivations to get them off or get the dose down. And the compounding was the way to do it more cost effectively.
Did you monitor any of these patients because looking at fibrosis to see?
Yes. Well, one is that the biopsy and MRCP, sometimes they would say there was less fibrosis. What we started doing more recently is elastography. And the last 4 patients we've done elastography. Both of them show less fibrosis. And you've had some more experience with this.
Are you doing ARFI or is it MRI elastography?
MRI elastography. And at least the 4 I did, all 4 showed improvement on the Vanco.
So for us at Mayo, the way it started was actually after the paper that Dr. Cox had presented. And my colleague at that time, Def Fries, came and said, well, we're seeing some improvement based on this paper. Let's try our patients with it. So we actually started using vancomycin for our PSC patients. So we'll go very quickly. I mean, we've gone through this, so I'm not going to make it very difficult for all of you. And I'll go over some of the pediatric aspects for our adult colleagues. So that's the prevalence of PSC in these patients and the association, of course, that all of you know between PSC and inflammatory bowel disease. I think those patients that have PSC without inflammatory bowel disease tend to be the exception, and they tend to appear at clinic at a later date because they already have demonstrated evidence of chronic liver disease, in contrast to those patients that present with IBD, and we tend to actually catch them early on by checking their liver enzymes. So the thing for adult colleagues is not all of PSC or PSC looking ERCP or MRCP are due to the classic known PSC. We see it in a variety of other conditions, including immune dysregulation. When we had cryptosporidium in my AIDS population when I was in Chicago, we had a lot of pictures that look very similar to PSC. And of course, 𝐀𝐝𝐝𝐢𝐭𝐢𝐳 and hyper-IgM syndrome do that as well. Again, in my experience, I think a lot of people would say, well, the presentation when you look at the adults is jaundice, fatigue, pruritus. By that time, it's already too late. For us, we actually will test for liver enzymes on all of IBD patients at presentation on a regular basis thereafter, every 3 or 4 months sometimes, and occasionally every 6 months to make sure that there is no evidence of liver disease. And it always includes a gamma GT because it's extremely sensitive to liver disease. And then we are very concerned anytime we have poorly responsive autoimmune hepatitis for the overlap syndrome. And when we look at the studies that were published, I'm sorry about the quality of this, this is the number of patients that have been shown, and what you see is that nearly 90% or more of patients have an abnormal gamma GT. Ariel Feldstein, when he was first-year fellow, looked at our 52 patients and looked at them 20 years down the road, showing that 50% of them will have either a transplant or death, showing that PSC in pediatrics is not a benign disease as it used to be thought. Of course, Mark Deneau has his patients that we have all participated in. And then for you, for people who are interested, this is the picture that you see in MRCP as well as the RCP correlation between the two. And the demographics of pediatric patients that have been studied so far by Fabian when he published this in 2001. This is typical feature of the onion skinning that we see, but I think this is an important component. The AASLD practice guidelines in 2010 showed that if you really have a high suspicion for PSC and the MRCP is non-diagnostic, then you have to proceed with an endoscopic study. And if that is negative, the biopsy is done. Now, adult colleagues at Mayo hardly ever biopsy a PSC because most of them already present with ongoing disease. They're not like caught early, whereas we try to catch them early. And that's been my experience in this. And of course, there was the study that was done with URSO, low dose versus high dose, showing high dose to be significantly worse for these patients, and therefore that was changed after that. But I'm not going to go too much with this, but this is actually from Ken's paper, similar to what we have found here, and this is actually the picture from his paper showing the improvement in the biopsy of these patients. And of course, now in terms of vancomycin, the other thought that I had about it is that there was a nice paper that looked at vancomycin use in patients with insulin resistance. And what they did in these patients that tend to be pre-diabetic or diabetic, they gave them vancomycin and looked at the microbiome, the change in the microbiome with a decrease in firmicutes and increase in protobacteria, as well as change in the conjugation of bile acids with the resultant increase in primary bile acids and a decrease in secondary bile acids. And secondary bile acids tend to be more toxic to the liver, and of course changes into the hormonal and the signaling pathway in the liver, leading to a peripheral insulin resistance that is increased. So this is the change in the microbiome in this patient population. These are not PSC patients; these were different, and there is certainly an effect of vancomycin on the gram-positive cocci and the decrease in the firmicutes. There is a group, the adult groups have a variety of different centers that collaborate by collecting blood data on many patients. The Norwegians have collaborated along with the British in multiple centers, and this study was actually shown recently, and I think it was presented in an abstract 2 or 3 years ago at the AASLD about genome-wide extension with patients with PSC. The study is always, unfortunately, biased because many centers will have, let's say, 150 or 250, and Mayo has 3,000 of these patients that they accumulated over time. So it almost automatically, any studies coming that includes Mayo will bias it to one institution versus the rest of the institutions. And the most robust association, which I was thinking about in terms of what vancomycin does, is there is on chromosome 19, Q13, there is a 𝐀𝐝𝐝𝐢𝐭𝐢𝐨 transferase 2 secretory status, which leads to interaction between the biliary epithelium and the gram-positive cocci. And it seems to be significantly affected in patients with PSC patients. And I always wondered whether those patients that respond to vancomycin versus that don't respond to vancomycin have a different genetic background, and not only their microbiome may be different as well. Anyway, so that's really the gist of my talk about it. So we can go ahead and open for any discussion and go over all the things that people want to discuss about the variables and what have you, according to if people don't have the agenda. Go ahead, any questions?
Can I ask a quick question for Dr. Cox for what you were talking about? I guess in terms of like outcomes for these kinds of studies, one of the things you mentioned was the improvement in the MRCP.
Yes.
Is there an objective way that's being measured, or is that kind of subjectively at the radiologist level?
Well, I think the radiologists, I do MRCPs generally annually in all my patients, and so they don't know what I have been doing over the year. But they then, well, it has changed, it hasn't changed. but we haven't had some sort of quantitation process. And so that's probably something good to do if you're doing a prospective study, is to have it blinded and have some way to actually quantitate the changes there. But I think the elastography is important because I think, again, in 4 of our patients, we did it in, it got better, and I think that would be another objective way to look at this.
All of our patients get an MRCP yearly along with an elastogram. And the reason for this is really the disease is nasty in the sense that it can be significantly progressive under the radar. And people need to remember that the half-life of these patients is, of this disease before you get into a significant worsening is 15 to 20 years. So when you talk about treatment, you really have to have the time frame for it. My experience is that if they responded with normalization of enzymes, the MRCP will either get better or never progress, and the fibrosis will regress as well. In my experience is that if they have small gut disease, it's better than large gut disease. And if they are early, they are significantly better than those that have already shown evidence of significant disease. I don't know what others.
One other comment I have is that 14 of my 59 patients were adults. We kind of looked and compared them with the pediatrics. And one of the things that was remarkable is they had more fibrosis and more cirrhosis. And so when we were looking at the liver numbers improving, theirs didn't improve quite as well as the pediatrics. So those that had no fibrosis or mild fibrosis normalized. Those that had some degree of fibrosis, I think, were less improvement of their liver numbers.
Sorry, anecdotally, I would say that's what I found. I only take care of adults, but I feel like the liver enzyme improvement has not been that impressive for me. Although the IBD
so you've tried
symptoms seem to get
vancomycin.
better. Sorry.
So you've tried vancomycin?
Yeah. In fact, this was kind of timely because we have a resident who was interested, so we just got our RIV approved and started looking at the smaller number of patients that we've treated. But I think it was partly our GI colleagues who were also using oral vancomycin for some of these UC patients. And they seem to feel like, at least on the adults, that they've had improvement for the UC, but I haven't really noticed that the liver enzymes have improved that much, except for a couple of people.
How many patients have PSC without IBD?
Very few. So I had this, I only kind of got interested into this because I had a patient who kind of talked me into doing this, that you might actually know, from about 5 years ago, and he's twice now, been on and then off vancomycin. He has no IBD, but has complete normalization of all liver tests, including bilirubin when he's on. When he's off, he actually came to me for a transplant evaluation initially for jaundice. It actually normalizes bilirubin as well with the disease.
Well, that's remarkable because usually the data coming from from Mark Deneau's group is that once you have bilirubin elevation, it's already quite aggressive.
Yeah, I have one patient that had cirrhosis and was being placed on our transplant list. And that was 12 years ago. She's had no progression of the cirrhosis, and her numbers are normal. And I was able to wean her vanco down to a low dose, but I haven't been taking her off because of the flares.
So the question also is how long you treat those patients. And the second thing that I think people need to ask the question is, does it change the outcome in terms of cholangiocarcinoma? If you have normalization of enzymes, or is there a different mechanism that drives cholangiocarcinoma? James, do you want to comment on your study when you did antibiotic with teeth, whether there was a difference between metronidazole and vanco?
There were some differences. I think vanco met the primary endpoint, whereas metronidazole, from what I remember, did not, although it did show some improvement in other endpoints that we assessed. So I think based on that finding, as well as prior studies and what we know about vanco's tolerability versus metronidazole tolerability long-term, I don't think any of our patients are on metronidazole long-term. Although I will say there is one patient I can think of who a essentially refuses to come off it because he's doing so well, and he's come off in Rochester, and every time we take him off, he becomes more symptomatic, more pruritus, particular. So we try to get him down to the lowest possible dose tolerable, but I think outside of that, I don't think anyone is looking at metronidazole as a long-term or durable evolution.
My experience also is that those patients that have PSC and ulcerative colitis that go on vancomycin, their colitis is much easier to manage. But this is, of course, few numbers. And I don't know whether you agree with that. It seems that they seem to require very little additional treatment.
Well, a number of my patients, I mean, I had one patient on Remicade that was not responding, and this is 3 years later, he's only on Vanco, has had no recurrence of the colitis, and liver numbers are normal. And so most of my patients' colitis, they're only on Vanco. They take them off of everything else, and they haven't had a flare. I had one that did flare.
Yeah, I had a few
that I ended up having to give Remicade because when I lowered the Vanco, she flared and I couldn't get it to go back, but her liver numbers stayed normal. I also want to say I do C19-9 on all my PSC patients, and I have about 8 of them that have high C19-9s, and while on Vanco they went to normal. And then the second thing was that I also looked at other factors like leptin. Leptin stimulates cancer growth. That was high and went to normal too on the Vanco. So I also, and we've not seen any cholangiocarcinoma on the Vanco.
Can you explain why there's a higher number of pediatric small duct patients than there are adults? Do they morph into large duct?
Well, maybe that we're diagnosing them earlier, because I think a lot of the adults probably have had the disease for quite a while before they got diagnosed. And I think we're picking up kids when they're 2, 6, 10 years of age, so that may be why. Maybe if we wait longer, the large ducts would be involved as well. I don't know.
Well, I think that's one possibility. The other is there one PSC or more than one PSC? I think for the purpose of studying a medication, I think it would be nice to have the data, but if you want to present it for as a grant, try to make it simple for the reviewer. So just put PSC, whether they have small duct or large duct, you can say we can look at them in terms of looking at data, but we're going to treat both and see if there is a difference down the road.
I really wouldn't exclude the small duct disease because those are the ones that are really very responsive. So,
do all your patients have colons?
Yeah.
I'm just trying to figure, will this work without a colon, or why does it work?
Well, actually, I have.
That's a good question.
I do have one patient that had a colectomy that came to me with PSC,
I don't think I have.
and the PSC went away on the Vanco, and this kid's actually, he's an adult now. He's been on it for about 5 years but he had a colectomy.
And I guess for anybody who's been doing this, you talked about dose reduction at some point for the people who are responders. I guess what arbitrarily, I guess, is there a time period that you wait where you consider, they're stable and then you would dose reduce, and then how much do you dose reduce?
So I think long term, one is most patients I can reduce the dose, and what I end up doing because of my experience is I wait 12 months before I start doing that. And then what I do is I drop the dose, like if I'm doing 500 3 times a day, I go to 500 twice a day. And I watch the labs for at least 3 to 6 months before I make the next step. Then I go to once a day, and then I wait 3 to 6 months before I do the next step. And then I think about stopping it at that point. And again, I watch it closely because some of the flares may be 6, 12 months later. So I keep watching labs every 3 months when I've stopped it to see if they flare. And there has been a subset that I've had to go to higher doses. I mean, I have about a half a dozen patients, and I've gone up to 1,000 milligrams three times a day because they weren't responding completely to the 500, and they responded to a higher dose. And so that's the other thing to know.
Well, to answer your question, that's why we need this group in the sense that we have followed similar guidelines as Ken has done. I usually will treat them 4 times a day for at least a month, sometimes 3 months before I would reduce. With 𝐀𝐝𝐝, I mean, this is not science, this is just the art of medicine. I think that I usually do not go to once a day because I don't trust a teenager to take things once a day, so I will actually always ask for twice a day dosing. So at least I can think, my thinking is that at least he will get 1 dose. Even if he or she, will get one dose. Usually it's a boy that doesn't want to take their medicines.
One other observation I've had is that some of the patients that I've been able to take off and they haven't flared, their antibodies all became negative. And so I have a feel that might be an indication of a higher probability to get off. So that's something I can keep an eye on, are the positive antibodies.
Well, that's something I didn't know, so that's something that we might do to really look at the markers that way as well.
And the other thing is doing colonoscopies on them. A lot of times they're asymptomatic. Their stool calprotectin is not abnormal, but they still have inflammation. And so I think it's important when you're going to start tapering them or take them off the vanco, let's do a colonoscopy, because I think if they still have some activity there, I think there's a higher probability that they're going to flare when you drop the dose or stop it.
And you're talking about microinflammation as opposed to visual or symptomatic.
Yeah, it's biopsy
Yeah.
inflammation. It's not visual.
I have a question about the main clinic experience. So I know that with Dr. Cox's patients, most of them haven't required immune suppression in addition to Vanco. Has that been your experience as well?
That is correct. The only ones that have had requirement for immune suppression were overlap syndrome, and these usually are difficult to treat. Now, there are patients who present with combination of autoimmune hepatitis and PSC, but in my experience, those patients evolve towards more of a PSC phenotype than an autoimmune hepatitis type.
I had one patient with a high IgG4 that had pancreatitis, colitis, and PSC that all responded to the Vanco. And I had one other patient that was in Israel that they used Vanco on with that high IgG4, and the IBD and the PSC responded to the Vanco. So that's one group. And then of my 3 patients that did not have IBD, one of them was 𝐀𝐝𝐝 positive, even though the scope was negative. So.
In terms of timing of when you start the treatment, I've heard from many patients that doctors want to see symptoms before they start treating. Can you talk to that?
GGT work, speaks louder. So I think if the GGT is abnormal, that's really an indication that there's ongoing liver disease. Chronic liver disease in a variety of conditions is similar to high blood pressure. You really have to check it to find out if you have high blood pressure before you get into trouble. And a high index of suspicion is very important with IBD patients.
And I don't think we check liver numbers in our IBD patients as often as we should be doing it, particularly GGT, because I do believe that there may be more PSC out there because they don't have symptoms at all that we're missing. And like this father of this kid I have that ended up having high GGT and PSC on his MRI. So, and I have another family where the dad's had a liver transplant, his brothers had a liver transplant, and the kid, they just happened to do liver numbers because of that, and the kid has PSC. So,
Mark Deneau's paper on the GGT as a response to PSC, he had a very hard time publishing it because the reviewers were mainly adult hepatologists that don't believe in GGT. GGT is inducible enzyme and will go up with alcoholism, you know that. And so that's how they know if an alcoholic is abstinent or not. Whether it goes up to medications and what have you. So but in patients with IBD with PSC, it's an extremely sensitive test for biliary disease.
I don't know too many. There's I think a lot of pediatric hepatologists out there who, none of us wait for symptoms to treat. And I think, there's a lot of different centers that have used Vancomycin, just, other things haven't worked. And So, you know, nobody, I mean, it's just like autoimmune hepatitis, you wouldn't sit there and wait when their enzymes are elevated to treat them until they, you know, waiting until they become symptomatic. So, and, you know, most of my pediatric IBD colleagues, they're really good. I mean, not now that I just work at Mayo, but the other places I've worked, they're also pretty good at screening GGTs in their IBD kids looking for liver disease. And as soon as they find that it's not normal, they send their kids. And I have another colleague who uses vancomycin who's down in Miami. So, but I think, you know, until Mark started to pull all this stuff together, there wasn't, you know, there were just cases here, cases there, kind of thing. Apart from your studies, of course.
In a way, I feel guilty and not guilty for using vancomycin as a treatment option for these patients, because we did it based on Ken's experience, and then we were gratified by the results, and therefore we didn't. But in you know, one could always be a 20/20 hindsight and say, well, we should have done it as a study with double blind and placebo controlled and what have you, which I think is something that should be done at some point. But I think so far we've had quite a bit of data to show that it works, and patients, of course, want things to be working for them.
Yeah, but part of the problem is always trying to get, you know, if you're pediatric, usually they want the studies done in adults first, and it's very hard to fund, and it has to be because none of us have like a ton of patients at any one center.
Right. Before you came, I was saying that we should become like the pediatric oncology group, where all of us in pediatric liver should have. Small, big centers. It's not like somebody who's doing 6 to 8 transplants versus 40 transplants in terms of how many liver patients they acquire. Every single one of these patients is a very important number to add to the power of the statistics that we have in this situation.
Well, and I think Keith Linders, who got a study,
Elizabeth Terry, she's the PI at Mayo.
and it would be nice to be able to do this in pediatrics as well, because I think
And especially if you end up finding it because you're treating them earlier, you start treatment therapy earlier. I mean, I had one patient with PSC who started with small duct disease, and at the time, I mean, this was a long time ago, but he eventually developed large duct disease. And then it was time to transfer him to adult care. But
So could it be, if you have an adult, 2 or 3% of the adults with small duct, this is a point that I keep raising, sorry, that this disease they're just early in diagnosis, and so that's what you're thinking, that they
It's
just haven't gotten
likely,
their
but really
involvement.
nobody really absolutely knows if these are 2 diseases or phases of the same disease.
Yeah.
The only way to find out is to the way you study disease is you take snapshots from the movie and then you try to reconstruct the movie.
Yeah.
So,
and there's the overlap, and I think that the overlap in my mind is not just, there's a scope of it, because I look at some of my PSC patients, they have ANA, anti-smooth muscle antibody. I mean, they have many of the same antibodies you see with, autoimmune liver disease, and so I think there is overlap between these 2 diseases, and I think some of them may have primarily within the liver and the small bile duct disease rather than the large bile duct disease.
I have a question for the adult colleagues. When you have your PSC patients, how often at the beginning and how often afterwards do you screen them for other autoimmune disease, including celiac and thyroid disease, or lupus or whatever that could be associated with? I do it on a yearly basis, or you do it only once?
Once, and then sit back.
That's it.
If they come in telling us that they're, losing weight and don't know why, they're going to get another TSH or another TTG from me. But truly, it's really the first time through.
My patients I'm fairly aggressive with, I do it every 6 months. But celiac, I probably overdo it because it's just the same requisition that I get. I don't have to keep sending them different ones. But it's mainly TSH and celiac I check for, and otherwise it would be clinic for lupus and other autoimmune diseases.
Ahmad Afsa in our group in pediatrics actually looked at the association between celiac and autoimmune polyglandular syndrome and showed significant association between the two, which was not described before. So that kind of opened my mind into autoimmune diseases. Birds of the same feather cluster together, and the idea is that I will go ahead and screen them yearly, regardless of symptoms. Are you going to treat your patients now with vancomycin?
Think about it. I have one who's post-transplant, and he's still on it, but I don't think it's changed much of anything. He doesn't want to come off of it. His insurance company's paying for it, so I'm keeping him on it. But he's had a couple of biopsies along the way because he's easy with the transplant. And so maybe we've stabilized his disease, but I don't think we've.
Now, it'll be interesting to do more data on it. And we're going to look into our 9 patients that we put on Vanco post-transplant, kind of get what was the long-term outcome in these patients.
Now, how many never respond? I mean, I've had patients that from the get-go have never responded.
Well, I had 3 that didn't respond very well, but I wasn't sure how much of it was compliance versus how much of it was the medicine versus the brand of the medicine. But all the rest, I mean, their numbers got, I had one of them that ended up getting eating disorder, getting admitted to the hospital. And I said, I'm done. So, with the Vanco, because it was much more complicated. But, yeah, so what percentage yours doctors?
A few,
Yeah.
but those that have not responded have already had significant ongoing disease for some time.
Okay.
So that's the first thing. And some of them do not respond at all to that. But I have not tried to go up significantly on the dose either. So that's another thing that we might do as well.
Let me flip the question back. What percentage of your patients with PSC are on, do you put on treatment? Because I'm trying to figure out who gets it and who doesn't get it.
I would try it on everybody with PSC. So historically, more than 50% of our patients are on vancomycin. The ones that were not on vancomycin had been tried on URSO and responded, and now that was a long time ago. Most of them are in the adult sphere. So most of our patients are on vancomycin.
Yeah, all of mine I treated with Vanco because I have research studies, but I have to get them to agree to it. But most of them come to me because they want to be on Vanco because they read papers and stuff. So, yeah. Anything to add?
I mean, I would agree. I worked with Dr. Cox and worked with him as a fellow in the study. And so I would say that we probably get a call every other week about someone needing to be treated. I think part of, a significant amount of my patients have been successfully on Vanco and done well. I haven't been afraid of Dr. Cox from taking them off. So I keep 500 3 times a day. But one of the struggles I do find that when we get calls and someone isn't responding or one of our patients stops responding, it's usually brand. Actually, they got switched to the pharmacy. So I just recently had that.
I think
patient who didn't respond.
I've seen this also.
Or we get calls that say, well, I tried vancomycin and it didn't seem to work. And it's usually because of the brand. So like Dr. Cox said, the brand that tends to be the only one that seems to have true efficacy. So we take a lot of time trying to get the pharmacy. But I've had many similar patients that have been on Remicade with one-time elevation of liver enzymes, weren't sure if it was Remicade, but they weren't responding on Remicade. They're going up and on my dose, and putting on Vanco was off Remicade, doing fantastic, biopsies and normal. And so we're getting calls, and I just got a call 2 days ago on a patient on these folks that's interested in treating, but I'm seeing just a significant response in the patients on the right dosing and the right brand.
What's the brand that doesn't work again?
So I've always used brand, which was by Biopharma initially. So we've kind of tracked this dose on when it got sold and when it went from pharmaceutical company to pharmaceutical company. But that is the brand. They make both a generic and they make the brand. So it's sometimes easier to get the generic through the pharmacy because the cost is not
No, but you said there's one brand that doesn't work.
Acorn.
Acorn.
And Alvogen has a similar capsule, so we had some issues with Alvogen, although I found that the 125 has a different capsule.
Yes.
And they seem to do okay on the 125, with 250 has the same capsule as us.
So, as an example, my daughter was on A&I, the insurance company insisted we go to Alvogen. Within 2 weeks, she started to get diarrhea and her liver enzymes tripled. And so, this was still within, they were very low, and so this was still within just normal limits. But the fact that that happened in 2 weeks, we switched with, it was enough evidence to switch back to A&I.
Well, I was surprised. I saw a patient in clinic last week, and she was on Alvogen. I said, how come she's doing well? Let me see your capsules. And it was 125 milligram brand, and the capsules looked more like A&I.
So it can be the inert ingredients, there's something about the way they're capsulized.
Now, my impression also, and you correct me if I'm wrong, is that our adult colleagues always, of course, skeptical because you see the other side of the coin, which is quite progressive PSC, and there has been so many disappointments with everything we've tried so far. Does that color your attitude towards PSC, or you're still gung-ho about trying anything?
Well, the problem is there's nothing else now anyway, so this is as good as you get. I'll use an analogy that I found is that, for autoimmune hepatitis, budesonide really ought to work great, but it doesn't.
Yeah.
And the reason it doesn't is because we only save it for the people who are failing therapy. So as an adult, if you're failing standard, this may not look as good as it does in pediatrics because you're applying it to the worst of the worst.
Well, always the few patients that are outliers can kind of teach you quite a bit. So I had a young man with common variable immune deficiency who got norovirus infection. I couldn't get rid of it. The only way that I could get him to get better, I actually asked him to open up the budesonide capsule and take one open and two closed, and his diarrhea improved dramatically. However, budesonide did get worse on his liver because they do get chronic liver disease from CVID, and budesonide in a cirrhotic patient is a no-no, unfortunately. He needs a bone marrow transplant.
It's interesting, I have families asking, should they use Vanco on autoimmune hepatitis? And I say, well, it's not the standard therapy. But I did have one patient that wasn't responding to steroids or any immune modulators, and I gave Vanco and the kid got better. So, but I've not used it in any other patient with autoimmune hepatitis.
Well, I had an adult that came to me about this patient that had features of autoimmune hepatitis that was not being able to get weaned off her prednisone, and I told the physician, try Vanco, and she was able to get it off.
So I think that we need to look at this too at some point, particularly those that aren't responding.
So one more comment about the brand. We do have a liquid kit brand made by Cutis Pharma called First Bank, and they have agreed to donate for all of our clinical studies for vancomycin. So if any of you are doing clinical studies, let me know, and I don't know how far that's going to extend, but that's what we're using for the FDA trial through Mayo Clinic.
And they're so much cheaper than the pills.
Yeah, they're about a third the cost. They've gone up since they were FDA approved, but they're more expensive than the formulation of the liquid kit, the IV formulation. But they're great flavored, they're pH balanced, and it's an easy way to go.
Is this going to be at a Canadian site as well?
That was, I'll talk to you afterwards. We substituted Mayo, Florida for Canada.
Oh,
Sorry.
You have it easier in Canada because your people collaborate better. Pediatric hepatologists is like herding cats.
Yeah.
That's interesting.
Well, no, one of the reasons is because in Canada, there's less centers.
Yeah.
So the number of pediatric hepatologists in Canada is much smaller in the bigger centers.
Well, as far as I know, there's not too much interest in prescribing Vanco for PSCers in Canada, either adult or, well, I know Dr. Eckstein is participating in this trial. It was. So there's interest on a research level, but not with the
I have a couple
actual-
kids from Toronto that are on Vanco that I've seen, so they responded. So.
mean, you should talk to Simon about getting this, no, he doesn't want to.
Well, I mean, it's case by case, but there's a lot of patients who are reaching out to me as a representative of the patient group saying, we can't get it.
Well, but on the other hand, if you look at the amount of, randomized controlled studies in peds, there's not very much.
Yeah, of course.
And so, Vanco is expensive, so of course the government's not going to.
The government's not paying for it. It's exactly correct. They're going to pay for care.
No, but OHIP pays for
Not medication. There's no national pharmacare.
Yeah, but you only pay a certain fraction.
Well, I know because I'm very good for it.
Right, but that, no, but there are other drugs. The reason you may end up paying for it is because there are some drugs up in Canada that are covered completely. I grew up there, I know that, I practiced there, that are covered, but the drugs that have not been approved, you have to pay out of pocket. And so I think, putting patients on without having a randomized controlled study with larger numbers, they're going to say, well, where's your proof? I mean, they make any other drug coming out. The reason that Vanco is accessible is because it's used to treat other things. So, it's not like a new drug coming to the FDA or the equivalent in Canada. So, if you don't have that proof, then you're not going to get approval.
Right.
And so that's why it's difficult to get a hold of now. I think, there needs to be some studies. Is the bottom line.
The bottom line is how do we all make that happen?
Well, I think that the suggestion that you guys had for having the network for the pediatric, and there could be for adult as well, where the study is, there's a protocol that's followed by all of the different institutions. We could get the recruitment done pretty quickly.
The UK has a child liver foundation, which is a group that takes all of the pediatric patients.
Yeah.
That, with parents that are interested in having their data, their children, their support groups, and what have you. I think that if we're going to study this long term, you have to have a blood bank where you keep the blood for DNA analysis and genome studies. And I think there will have to be also microbiome before, during, and after treatment, whatever.
Right.
I mean, in North America, actually, it's larger than North America, but if you look at SPLIT, which is studies in pediatric liver transplantation, Toronto's involved in that, we're involved in that, there's a bunch of centers, pediatric centers, because there's never enough numbers to look at, treatment for rejection or anything else. It has to be a multi-center thing. And now part of SPLIT includes Australia, New Zealand, and so if you get a similar group like that, then these studies would be doable, and then you would have evidence that, then you wouldn't have to pay out of pocket for vancomycin. But that's the problem, is that right now for the governments to make a decision by using this, they go, well, I have a few cases here, a few cases there. It needs to be a multi-center randomized control trial looking at the benefit. And I think to do that, at least in peds, because no one center has enough, it has to be a multi-center, but it can be done because they've done it in SPLIT.
Do we know which centers have which number of patients?
Well, I have a list for the ones that were participating in PCORI back when so I know as of that period of time when we were about a year ago, I know how many patients there are in the centers. And so that was about 13 centers.
But I think there's, because I was using it in Delaware when I was there.
Yeah. Oh, well, this is just the number of patients and the number of patients who are on, how many of those were on vancomycin, like Philadelphia had 5 versus 40 patients.
Why would Philadelphia have only 5?
On Vanco?
Yeah, versus all of their patients.
Those are probably the patients whose parents were advocates and trying to get them put on it. So there's a resistance unless the parents are really pushing, like me, I think.
It's really hard to get someone to agree to give your child Vanco.
Well,
I didn't have to be I mean.
I had one patient from Philadelphia that had 2 liver transplants through PSC, came to me, put on Vanco because the second liver transplant had recurrence PSC, got better, and I think that influenced them to think about it.
But I think until you actually have these studies, you know, the one off here, the one off there, it's just not going to be the same thing.
It's not going to be the first line of treatment, like
And get you
we have 40 patients at our center. My son is treated, and only like 3 or 5 of them are treated.
No, you gotta get a multi-center study.
Yeah,
I mean, and the
Really
patients
important.
and parents want the evidence as well.
Oh, yeah,
I'm
for
sure
sure.
this
Yeah.
one is not their only choice without that evidence.
Agree with that.
No, and I think that's why, you know, it's done with Split. I know, like, my colleague in Miami is using Vanco. I was using it when I was in Delaware, so there are, you know, because.
There may be other centers using Vanco, but not advertising it or not.
Right.
I've got a running list of doctors who will prescribe it.
Yeah, to participate
And when
in the
patients
randomized
contact me,
controlled
I've got,
trial.
my list of where you
It's
can
all
go.
about evidence-based medicine.
I'll share it with you, and maybe you can add to it.
Guess-
We were just having anybody
Share it
who,
with
if you could,
Kathy. She's gonna be.
okay, all right, well, and I'll talk to you. I'd like to get your email. We're going to try to publish an article on this conference right now, so at least we'll get, we weren't on the agenda, but.
Thank you.
Yeah.
Now.
Yeah.
Thank you very much.